very much for allowing me to speak today. I hope my task is to talk you into why we should be doing more in spinal pacing. That's the summary. And so what I'd like to begin with is, let me see if I can, there we go, okay. So as you know, in pacing, the natural conduction is through the His bundle, and it activates not only the right bundle and left bundle, but the ramifications of those bundle bands aren't just that it activates at one site, but multiple sites in both the right ventricle and left ventricle to allow for synchronous intraventricular contraction. We've established a basis of RV pacing to allow for the correction of heart block. But that initiates an electrical impulse that usually starts at the endocardium of the right ventricle and then extends to the left ventricle through cell-to-cell interaction and slow conduction. There's no recruitment of the Purkinje system to allow for multi-site activation. And when we go about putting in left ventricular leads, we're putting them on the epicardium. And again, we're not taking advantage of the entire electrical system that we use naturally every day. So some of the evidence to convince you that RV pacing is bad for you is, I think, one of the most compelling is the David study. And that was a randomized study taking patients who had left ventricular dysfunction or getting a defibrillator, and were either programmed to a single chamber device, DVI, at a backup rate of 40, or DDD mode with primarily ventricular pacing. And in those patients, about 60% of RV pacing was occurring in that. The outcome was not what was expected, and that was that there was an increased incidence of heart failure and death up to a hazard ratio of 1.6 when patients were being ventricular paced, as opposed to the VVI group, which again was just a backup pacing of 40. And this actually was sentinel in terms of changing practice patterns throughout the world to try to limit ventricular pacing, especially in our patients with left ventricular dysfunction. Now, going back a little bit, many of you will remember the MOSE trial. This was a trial designed with over 2,000 patients that was designed to try to show the benefit of dual chamber pacing over VVI. So it was randomized between patients getting VVI versus dual chamber pacing. And yes, it did show that dual chamber pacing was superior to VVI pacing, but it was because of the lessened incidence of AF. However, in looking at a subselection of that, patients that got ventricular pacing, the more ventricular pacing they developed, the higher the risk of heart failure there was. So this actually is this is sort of a set point too, because when we look at patients that present to us who we put a dual chamber pacemaker and later on they come back with left ventricular dysfunction, we're kind of looking for that somewhere between 20 and 40% pacing, knowing that that's the group that's going to be, because this may be RV pacing induced left ventricular dysfunction. But for every 1% pacing, even under 40%, there's a 5.4% increase in incidence of heart failure hospitalizations. The Danish trial was another trial that looked at patients with sinus node dysfunction and intact AV conduction. And they randomized, this was trying to look at, well, let's look at AV intervals if we program an AV interval short versus a really long AV interval. And they were looking at left atrial size and left ventricular function. But as you see, they also found that atrial fibrillation increased, again, the more you ventricular pace. So this was a long AV interval, about 300 milliseconds. This is the AV interval, 150. Of course, you'd expect more ventricular pacing when you're at a shorter AV interval, but you're also seeing a higher incidence of AFib. So just like a pharmacologic approach, when we look at drug effect, and the more drug you give, the more effect you get. The more V pacing you give, the more effect you get, which is not an effect we want, which is the atrial fibrillation. So what's happened in the industry is we've all tried to say, okay, how do we work around this? How do we limit ventricular pacing? And that's now done through algorithms like this, which is called the mode switch. Mode switch, the MVP, which is where the AV interval is allowed to conduct and extend out longer and longer until there's actually a block beat. There'll be a backup pacing, but if you find that it's lost 2 captures, it will then ventricular pace, followed by giving another long AV interval. And what you find is very bizarre EKGs with this. Lots of times AV intervals of up to 300 milliseconds. Again, we know that long AV intervals are not physiologic, and in fact they're also predisposed to the development of atrial fibrillation. So I don't want to beat you down with data, but there's another study called the SAVE study, again looking at patients with sinus node dysfunction, intact AV conduction, and normal QRS, and they were randomized to conventional dual chamber pacing, and then using the modes, this MVP type of a response. And you'll see that again, atrial fibrillation is less the less ventricular pacing. So it's a really consistent finding. The more ventricular pacing you do, the worse it is. Well, a lot of you will say, well, so let's just put the RV lead somewhere else. Let's not put it at the apex. Let's put it at the septum or somewhere up near the hip bundle area. Well, the problem with this, first of all, is that it's pretty hard to standardize on fluoroscopy where you're putting this. I mean, realistically, how do you know you're not putting it here versus here in the outflow tract? Or are you putting it right on the belt? There's no standardization there whatsoever. So it's really hard to compare these. And in fact, when you look at this is a meta-analysis of all non-RV apical pacing compared to apical pacing, it becomes a scattergram. There is no proof that, or consistent data that says that there's less AFib or less heart failure. There may be a little bit of an improvement in LV dysfunction, in LVEF with non-apical pacing, but there's been no clinical outcomes despite multiple studies and done over the years. So it's not standard of care to necessarily put an RV lead in a non-apical position and expect that you're going to have less AFib or less heart failure. Now there was one study looking at, and they were either randomized to hip bundle pacing versus RV apical pacing. So these are people who are going to be paced, and looked at heart failure hospitalization outcomes. This is hip bundle pace versus RV pacing, and mortality, which isn't necessarily quite statistically significant. You can see quite a bit of a difference in heart failure outcomes in people that are hip bundle pace versus RV pace. So although there's no randomized controlled trials for hip bundle pacing versus left ventricular LV by V pacing, we can say that from a standpoint of RV pacing alone, hip bundle pacing is likely superior to RV apical pacing. And finally, the BLOCK-HF study. This was the study looking at patients with mildly decreased LV function. This was EF less than 50%, who had either very New York Heart Association, 1 to 3, who got either a bi-V pacer or RV pacing, and looking at outcomes. And there was, the endpoints were left ventricular size, ejection fraction, and then clinical outcomes, heart failure, atrial fibrillation. Well, there was a benefit, especially in left ventricular size, with bi-V pacing over RV pacing. These were patients with long QRS duration. However, when you look for the clinical outcomes, there was no difference. So we do tend to bi-V pace patients who have left ventricular dysfunction in that 50% range, 50 to 40% range. But yet, we may not be getting all the benefit we could get if we could use even more physiological pacing. So what I would conclude at this point is that I think we can say pretty consistently that frequent RV pacing, that is 40% or more, is not going to have good outcomes in terms of development of heart failure or atrial fibrillation. That alternate site pacing isn't really shown to be superior to even over RV apical pacing, especially for the clinical outcomes. Bi-V pacing is equivocal in terms of clinical outcomes for those with only mildly reduced LV dysfunction. And then his bundle pacing, I think all of us would agree, is physiologic in nature and that it's going through the intact conduction system. And it has a lot of promise in terms of clinical outcomes. That we don't have the data on yet. So I was going to go over, that was the why. So now the how. This is an example of a patient of mine who had an atrial fibrillation ablation and then for chronic persistent atrial fibrillation and later developed left atrial flutter. And she had ejection fraction of 45% and did not want any other procedure. She wanted something completely definitive. And so she elected to have an AV node ablation. This is her post-ECG. Bundle pacing is not, it's been around for quite some time. But the reason it is taking a resurgence is because there's new tools. And these aren't essentially very expensive or fancy tools. It's just that they've been more physiologically developed to allow you to deliver a pacing lead at the HIS bundle. And that includes these two sheets. One is the 304, C304. This is like the deflectable Attain sheet used for coronary sinus pacing, although it's a 9 French instead of 11 French, but it has one primary curve term. And this is useful for patients with really large right atriums to reach. The workhorse, though, that we use about 95% of the time, is a C315 sheet. And this has got a primary curve here, but although you can't see it in a two-dimensional photograph, there's a secondary curve that points backwards here. So it curves like this and then like that. And this allows, this is a 7 French sheet, and it allows you to deliver the lead, which is a 3830 bipolar lead. This is a 4 French lead, 4.1 French lead with polyurethane coating. And it's bipolar. It is not stylet driven. It's got an exposed screw on it. And this allows this lead to be delivered to the HIS bundle. What we do is that we put the lead into the sheath here, like this, and just expose a little bit of the helix just outside the sheath, and then record from the tip to the clamp here, unipolar, and record a HIS bundle. So a lot of people, when they first start, will often put a HIS bundle catheter in, but I didn't find that necessary. You can really map the HIS bundle pretty accurately with this. The other thing is that what you find is that you get really good HIS bundle recordings. This is an example of that same patient. Now, when you're doing this on you're usually using the analyzer for this, and you're using the atrial channel because it allows for higher sensitivity, and you're sweeping it at a 50 millimeter per second sweep speed. But you'll see a HIS bundle spike and then the V. You'll also see the atrial activity here. Now, where this is put in is actually the majority of the time we're putting this in right at the distal end of the AV node, the beginning of the common bundle of HIS. It's actually atrial to the septal leaflet of the tricuspid valve. So you're in that membranous septum area there, which the right atrium communicates. Remember some of those foramen valves, those other valve or foramen, I think it's ASDs that would go between the atrium and the ventricle, or VSDs. So you can record the HIS bundle and then the ventricular electrogram, and again you'll see the flutter waves as well. You have to be careful because sometimes you'll get very large A waves here, and you'll actually capture the atrium, and you'll say, oh, I've got this great position, but you're actually atrial capturing and not ventricular capturing. So once you've identified that, you go ahead and pace from there, and what you're looking for optimally is to see, here's the pacing interval here, and the QRS here, about a 40 millisecond difference between the onset of the pacing and the activation. So you're actually looking on the screen. The first thing you want to do is make sure you're not atrial capturing if you're let's say you have intact atrial activity. The second thing you're going to be doing is looking to see that you actually capture the hiss. Many times what you'll do is you'll come out at high output and see that your ventricular capturing, as you come down on the output, you actually lose ventricular capture and get hiss capture. There's two terms that you need to know here. One is selective hiss capture and the other is non-selective hiss capture, and I'll show you examples of that in just a second. This is the chest x-ray post-ablation. You'll see the atrial lead here and the hiss lead here. This lead's been around for a long time, just to let you know. It has a 10-year survivability of 97%. It's used a lot in children because of its small size. So it is an established lead. It's not something that you would expect to have a high failure rate. This is the post-ECG, and you can see selective hiss capture here. The QRS duration is about 117 milliseconds here. This is another example of someone who came into the hospital with complete heart block. The left bundle branch block escape here. And this is the post-ECG after putting in the hiss catheter. This is they had a right bundle as their underlying other conduction system disease, but it really gives out nicely how you can see the the spike here and the interval, the 40 millisecond interval before ventricular capture. So going through the his Purkinje system and activating the entire left ventricle. So this is what's called selective hiss capture. So there's a little interval, there's no delta wave on the ECG, and the repolarization is normal. Whereas non-selective hiss capture looks like this. So what's happening is you're capturing, you can see the QRS is relatively narrow, it's not a really wide QRS, but you're getting that essentially little delta wave there. And there'll be the T-wave abnormalities that will be associated with it. So this is non-selective, and this appears to be equivalent to selective hiss bundle capture in terms of the benefits, physiologic benefits. So selective versus non-selective. So what I would say is the candidates for hiss bundle pacing are those patients that come to you with AV node block, second or third degree, which we want, infranodal intrahiss, AFib pain. So people, to summarize, it's really simple. People who you expect to be V-pacing in a significant amount, meaning over 20%. So of course AV node ablation where there'll be 100% pace. And patients who you think they're going to have a long AV interval because they already have a marked first degree AV block. There's another group of patients that you would expect that you're going to get more physiology by pacing the ventricle. High burden, especially if they've got EF of 45 to 50%, that block HF group, ICD patients that you expect that you're going to have a high burden pacing. And this is a patient group that I think is we haven't thought about before, but those patients we were doing CRT placement of left bundle, and we couldn't get a left ventricular lead in because of the anatomy. You might consider going back and putting in the hiss lead in that LV port. In fact, something we've been doing more and more is actually now starting, and this is just recently, starting to try to put in our patients with who have an indication for biventricular CRTE, putting the LV lead actually in the hiss position, and plugging it into the LV port, and allowing pre-excitation of that LV lead before the RV lead so that you're actually hiss bundle pacing. And about 75% of the time you can narrow the QRS, even though they have a left bundle branch block. So I'll show you one more case. This is a patient of mine that early on, the thresholds, we typically will take a hiss bundle threshold of about 3 volts or less. And you program the pulse width duration to 1 millisecond instead of the usual 0.4 milliseconds. And this is a patient who had AV block, atrial fibrillation, and you can see selective hiss bundle capture here. Very narrow QRS, normal thing. But if you go down ECG, you'll see intermittently there's V pacing here. Now this patient had a different a system I put in because the LV lead, his capture threshold was right around 3. I wasn't exactly happy with that. I knew that they had to have ventricular, backup pacing. They had a complete heart block. So I put a dual chamber pacemaker in. In the atrial port, I put the His lead, and in the ventricular port, I put the RV lead, and I put that in the RV apex. And so they came in like this, and I said, well, this isn't, this is optimal. Why am I getting ventricular pacing? Well, if you interrogate, what was happening is intermittently, you could see their atrial sensing, and they would intermittently, that atrial sensing would fall out of the post-ventricular refractory period, and even though it was an atrial fibrillation, it's intermittently asensing and then deliver an atrial capture. And we saw more of that as we went through the interrogation of asensing and intermittently ventricular pacing. So what we had to do is we programmed the atrial sensitivity less sensitive, and we could inhibit that, and then now there's complete ventricular pacing. So I hope what I've done is help you understand how I think this is a very promising therapy. It isn't going to require a lot of resources. Initially, it is time intensive. The first time I did this, it took me probably 2 hours to put a His bundle lead in. But now it's gone to less than 15 minutes. So I think in all studies it's shown that where an experienced operator can put a dual chamber pacemaker in someone in 30 minutes, it may take you 45 eventually. The lead stability is very good. There's less than 3% lead dislodgement within the His bundle lead. And the thresholds, for the most part, only about 5% of the time do they get too high that you would have to revise it. And then I think that in the long term, clinical outcomes will come. Thank you.